Ketil Størdal from Norwegian Institute of Public Health will come and tell us about the common exposomic determinants of immune-mediated diseases.
Thank you, Jutta. My affiliations are a bit more complicated. So I'm a professor at the University of Oslo, but also working as a pediatrician at the Oslo University Hospital and affiliated with Norwegian Institute of Public Health in this project. First of all, I would like to point to that exposome really matters. As mentioned by Jutta, we have seen an increase in autoimmune diseases the last decades, and in pediatrics, this is very evident that previously we had a large number of infections that were keeping us busy, especially during outbreaks and seasons. But for several reasons, these are better controlled these days. They are not eradicated, but what we see is an increasing number of children with chronic diseases and immune-mediated diseases like type 1 diabetes, inflammatory bowel disease, celiac disease, asthma, and so forth. But why should there be any common exposomic determinants? Which is the title of my talk. Why should we look for any common exposomic determinants? The first point is that there is really a co-occurrence in autoimmunity. This means that, for instance, if you have type 1 diabetes, you at the same time have a clearly increased risk of celiac disease, which is estimated to be 5 to 10 times increased. There's also an increased risk of thyroid disease, but in pediatrics, we are at the moment missing the overall picture of overlapping co-occurrence of autoimmunity, but that's something that we are working on. But it was recently published in Lancet from a big UK cohort about this overlap phenomenon for different autoimmune diseases, some of which are not prevalent in pediatrics, but some clearly are. And we have preliminary data not yet published about co-occurrence of 6 immune-mediated diseases in childhood, and those are type 1 diabetes, celiac disease, autoimmune liver disease, inflammatory bowel disease, thyroid disease, and juvenile idiopathic arthritis or joint inflammation in pediatrics. For this project, we have used every child born in Norway since 2004 up till 2020. And linked them to the Norwegian patient registry, also to the prescription, to the vaccination registry, and to Statistics Norway for different purposes, which means that we have a cohort with 6 different autoimmune diseases. And what we have found, these data are preliminary, and we are just getting updates with a bit longer observation period now, but we found that type 1 diabetes was quite frequent as previously known, 33 per 100,000 person years. Celiac disease was the most prevalent one at 76 per 100,000. Liver disease 1.4, quite rare, but also inflammatory bowel disease is found. Thyroid disease and juvenile idiopathic arthritis were quite similar in the incidence. And the question now is how much overlap do we find and co-occurrence of disease? So we found 12,431 incident cases, but when we look at how many children are affected, these numbers were lower at 11,883. And looking at how many have got 2 diseases or more, we found that 4.4% actually had 2 or 3 conditions at the same time. So co-occurrence is quite common in autoimmune diseases in childhood. And what could explain this co-occurrence of autoimmune disease? I guess that shared genetics is something that we really have to take a look at, but also shared environmental factors, which is the focus of the exposomic approach and the HEDIMED project. We should also be acknowledging that there is a bit of surveillance bias, and this means that if you have one disease, for instance, type 1 diabetes, you are subjected to regular screening for celiac disease. Every year you're tested, and this means that your celiac disease will be detected in type 1 diabetes And we know that without any risk factors, you may remain undetected for many years. But also some thyroid disease screening is ongoing, not as systematic, but this means that there is a risk of a bit over-exaggeration of this co-occurrence. But nevertheless, there is clearly a co-occurrence, and shared genetics is not the focus of this project, but just mentioning that we have some very important contributors in the genetics called HLA genes, or the major histocompatibility complex proteins. These genes are on chromosome number 6, and they encode for HLA molecules in class 1 and class 2, which are present on the membranes of most cells in the body, including the antigen-presenting cells. And peptides are presented in these specific HLA molecules and can drive autoimmune diseases, which is very well known for celiac disease, but also for some of the other diseases, even though we don't know the exact peptide. But when we look at HLA risk genes, we know that for type 1 diabetes and celiac disease, which are having very much in common, HLA DQ2 and DQ8 are found in most cases. In celiac disease, almost everyone has DQ2 or DQ8. In type 1 diabetes, it's not as clear, but clearly increased. If you carry both DQ2 and DQ8, you have the highest risk of ever getting type 1 diabetes. But also for other conditions like liver disease and inflammatory bowel disease, they have shared genetics on the HLA class 2. And also for thyroid disease and for juvenile idiopathic arthritis, HLA genes are very important. However, they are not necessarily shared between all these 6 conditions. And I think that genes are not sufficient to explain the overlap or the co-occurrence of autoimmune diseases in pediatrics. So we should look for the shared environmental factors. And I'm showing a picture of the globe just to point out that for most of these diseases, we know that the risk is higher if you live far from the equator. So northern regions of Europe, also Canada, and northern regions of the US, but also south of the equator, it tends to be an increasing risk if you are moving from the equator, and low risk if you live close to the equator. Of course, this could be due to many causes, including poverty and socioeconomic factors. And that's why I think it's also interesting to have a look at a single country where we have kind of the same health system and the same state of living. And these are not yet published data, but we have looked at the risk of autoimmune diseases in Norwegian cohorts, the one that I showed you from the Norwegian Birth Registry. And we know that there is a clear north-south gradient for instance, juvenile rheumatoid arthritis. And the risk is approximately twice as high if you live in the north as compared to the very south of Norway. But also for inflammatory bowel disease, we have found the same. For type 1 diabetes, there is also a slightly increased risk if you live in the north, and also for thyroid disease. And we don't know the explanation for this phenomenon, and that's something that we are working on and trying to find out in an exposomic approach. And exposome, just to share a bit of the things that we are working on, is that health and disease are determined by the specific external environment that you see in the balloon at the left side, which contains diet, toxins, activity, medications, and so forth, also as presented by Pano recently, but also the general external environment, which is more the macro perspective with the climate, whether you live in a polluted area, urban living, or if you are surrounded by green spaces. In exposomic research, we are trying also to measure the internal exposome, which is everything which is going on inside the body. And linking these together is the ambition of the exposomic approach, not looking only at how internal exposomes are determining health and disease outcomes, but also how specific external and general external are linking to the internal exposome and further to health and disease. I just want to highlight one example that we have focused on in HEDIMED, which is about the green space and the importance of green space, also mentioned by Aki in the first presentation of this session. Natural soil exposure or green space can be measured much more accurate than has been done in the past. There are numbers of publications on how the incidence of disease differs between rural and urban environments. But the ambition now is to measure this more accurately by using satellite images of land cover, which is giving a much more precise measurement of the level of exposure, because it's possible to live in an urban setting and be surrounded by greenness, and the opposite for rural livings as well. And this is a picture of satellite images from the inner part of the Oslo fjord. This is urban Oslo with built areas shown in red, but also with agricultural areas shown in yellow and forest in green, wetland and salt water, etc., shown in different colors. And then you can map out how you are surrounded by your home address. Preliminary data, not preliminary, these are published data, but also from our colleagues in the DIP cohort in Finland have shown that there is a low risk of type 1 diabetes for living on agriculture compared to urban land. And from colleagues in Canada, they have shown that there is a low risk of inflammatory bowel disease with increasing green cover around the dwelling. And this has notably been found both for urban and rural place of living. So it really matters to have much more detailed measuring of the exposome and your living conditions than just separating urban from rural, because greenness may differ. Our colleagues in Denmark in the COPSAC cohort, which is also part of the HEDIMED project, they have found that atopic disease is higher in urban living, but also that this may be modified or being driven by differences in the microbiota based on where you grow up. Just showing a highlight from the publication from Jackie 2023, where they have shown how the microbiota is changed from living, from your birth, based on where you're living. So Copenhagen area and other urban areas shown in yellow, and more rural areas shown in green. And here you see that some microbiota are typical for those living in urban conditions, shown in the upper part of the panel, and other are more relevant for rural living. And at the first week of life and 1 month, not a lot is explained by your surroundings, but at 1 year of age, approximately 6% of the variation in the microbiota are explained by your greenness surroundings. And this is something that we really want to look into in more detail in years to come. When looking at the full picture of the exposome, I think it's very important to say that the specific external environment and the general external environment, that's something which can be modified, whereas looking at the internal exposome, this is less easy to change because it's modified by your external environment. So these can be seen as intermediate factors. To summarize, the exposome is still an emerging and exciting field with large blank areas on the map, which we should strive to fill out in years to come. And cooperation is very important for more robust research, like we have seen in the HEDIMED project so far, but still we have lots of data which we need to speed up to get out. And it's like to be a bumpy road to identify really causal pathways, because small effects are expected, and also some false findings that we need to be aware of when we look into exposomic research. And the missing links are clearly there, but we still need to strive to find them. So thank you for your attention, and these are the partners of the HEDIMED project.